All right, thank you, and welcome to the final witness panel here for the 2017 Cost Trends hearings. The title of this panel is Achieving the Healthcare Cost Growth Benchmark in 2018 and Beyond. And for this panel, we really want to focus on those forward-looking strategies to help the Commonwealth meet its goals in terms of improving access to care, the quality of care, and of course, the affordability of that care. We've put together a few of the key themes that we've heard over the course of these two hearings on this slide, and this is not an exhaustive list of some of those key strategies that we've heard, but certainly we've heard a lot around the need to strengthen and support primary care, behavioral health, both mental health and substance use disorder, and the potential for team-based models of care that can coordinate the whole person needs of patients as a key strategy to reduce avoidable hospital use, as well as improve care for patients. We've heard about the need to account for socioeconomic factors as appropriate in different payment policies. We heard from many providers and hospitals yesterday that addressing underlying payment disparities is essential for them to be able to sustain some of the work that they're doing. We talked yesterday about the need to continue to monitor where patients are receiving community care, either at teaching or AMCs or in the community, and evaluating other measures for evaluating success of providers being able to provide right care at the right time and at the right place. We just talked about the need to continue to improve our APMs and payment methodologies to reward providers for providing high-value care, to move away from a fee-for-service payment methodology and architecture. And finally, HERD needs to improve financial incentives to reward consumers as they choose high-value health insurance products and providers. Not an exhaustive list of some of the key strategies, but wanted to reflect with this panel, with this group, some of the key things we've heard over the last 2 days. And with that, I will turn it over to the chairman to tee off this panel.
Well, again, thank you all for coming to the commission. Several of you are seasoned veterans, having been here before, but a couple of you are new. So what we would like, if you would just briefly introduce yourself and your organization. Our commissioners are not shy. We will ask questions, and I'm sure during those questions you'll be able to articulate any particular messages you'd like to leave. As David pointed out, we've just had 2 very productive days, and we look forward to this effort because it really shapes how we look at the problem. And as David and others pointed out yesterday, on the one hand, we all want to thank you and those of you in terms of the fact that we've managed over the last year to get under the benchmark, and even over the 4 years to be just below the benchmark. And I'm sure the activities that many of you were involved in helped us do that. On the other hand, we're not about to declare victory. We need to be at it. We're not, we're just part of the act, but the key is going to be what you guys are doing. So we're going to ask some questions. So why don't you begin, introduce yourself and which organization you represent, Rishik.
Sure. So my name is Rushika Fernandopoulos. I'm the co-founder and CEO of Iora Health. We are 6 years old. We're a de novo provider group based here in Boston, literally right next door. And we've been trying to build a new model of primary care from the ground up, working with employers and Medicare Advantage plans. We have about 24 locations in 8 different markets. 3 of them are here in Boston. And our goal is to build a new vision of where we think we ought to go. So happy to be here.
Going to learn more about your activity. Kevin?
Great. My name's Kevin Tabb. I'm the CEO of Beth Israel Deaconess Medical Center and of the Beth Israel Deaconess system. I think you all know, and I won't need to describe it in detail. The only thing that I do just want to say is that I know that we've got an important matter that's pending before the HBC that's not the subject of today's panel. But I will welcome and appreciate the review that is coming, and I look forward to discussing that in detail with you in the future.
We promise to leave that part for another time.
I liked it though, Kevin. Good morning, everyone, or good afternoon. Yeah, it's morning still. My name is Eric Schultz, and I'm CEO of Harvard Pilgrim Healthcare. I'm glad to be here this morning. Thank you for the invitation. I think it was an invitation or a demand. Either way, it's good to be here. I don't know how many years it's been. Let me just say a couple real quick things. First of all, I believe, yes, we've made great progress in this past year. We feel very good at Harvard Pilgrim, the progress we've made, but we are also quick to say we have many opportunities for improvement, and we appreciate the opportunity to learn from one another here, truly, the ideas that come across. And, you know, I think this has been one of the more important and successful strategies that the Commonwealth has taken to create this commission and to keep a spotlight on what we're doing, what we're not doing, measuring so we can better manage. And all the more reason to keep this effort going because it's made a difference. I support that. We support that. Let's not let that go. I tip my hat to all of you on the commission. Thank you for what you do. I say thank you to those that are on the panel here. I also want to tip my hat to this guy to my left who I just met. He's our token pharma guy. And a very good guy, too. You know, I have a few things to say about pharma pricing, but he'll be glad to know I don't have any life-size posters that show the pharma practice or pricing practices of Astrazeneca over the last 5 years. Actually, all kidding aside, we have 2 outcomes-based agreements with Astrazeneca, and we appreciate the innovation and the spirit that they've come to the table with. So well done to those guys. Good to be here.
Richard?
Yeah, I think my table banner actually says token pharma guy. I'm Rich Buckley. I'm the Vice President of Global Corporate Affairs at AstraZeneca. We're a global science-led biopharmaceutical company. We focus our efforts in 3 primary therapeutic areas, oncology, cardiovascular diabetes, and respiratory. We, in 2016, invested $5.9 billion with a B in R&D worldwide, including the efforts of a few hundred very smart and dedicated scientists out in Waltham that lead our oncology small molecule efforts. In addition to pushing the boundaries of science, which we're very proud of at AstraZeneca, I think we also have a reputation for being forward-leaning in a number of different areas, including access and affordability programs, as well as some commercial innovations, including innovative contracts. You just mentioned we have 2 with Pilgrim. We have a couple dozen already signed and more pending. So thank you for the opportunity to be a member of the advisory committee and to be here today, and look forward to the conversation and answering your questions.
Well, thank you very much, and thank all of you. Just let me start it off, and then I'm going to turn it over to my colleague. Rashika, I'm more than a little interested in what's innovative and what you're doing and how you look at our system to sort of make it better, higher quality, and keep the cost in line with our ability to pay for it. So what are you guys doing?
Yeah, so we have the great advantage of starting from scratch. We're not trying to run a legacy business. We said, what if we wanted to build a delivery model which is purely in the world that we think it ought to be, which is really 3 pieces. Is number 1 is it's pure play value-based, right? The job is purely improve people's health, keep them out of trouble, and do whatever it takes, right? Not try and fill hospital beds or generate more visits, but take a population of people, improve their health. Number 2 is really this radically consumer-centric, right? I think too much of the healthcare system is designed around our needs as providers, not around the consumer. And 3rd is digital, right? That's what's happening. If you take that seriously, we said, how do you build a system? And really it's 4 parts. So 1 is you have to change the payment model, right? Fee-for-service is the wrong way to pay for this, and so we need to change that. So we purely work in value-based arrangements, which means everything starting from a primary care cap to primary care cap plus savings shared all the way up to what's commonly would be called as global risk. That allows us, it's fundamental, right? And that's all we do, right? We're not taking practice and having some patients under this arrangement, some against another arrangement. It means that we can fundamentally change the job. The job to be done, to quote Clay Christensen, is not see 1 patient at a time, do the best you can, but we have a population of people, they're a problem, do what it takes to improve their health, keep them out of trouble, and be really creative about it, right? And then that evolves a very different delivery model. So it's radically team-based. Lots of these folks called health coaches who are from the community, picked for empathy, help patients execute on the plan. Lots of non-visit based care, shared care plans for every patient, addressing social determinants if we need to, group visits, proactively reaching out, and then helping them navigate the system by finding the right places to go, co-managing with hospitalists, trying to find a small group of specialists we can work with. We've had to build our own IT platform. So these IT systems, the Epics and eClinicalWorks and the like, are unfortunately built for the old system. They're built to help you document, code, and bill hire. So we've had to evolve our own model and really build a very different culture around doing this. It's not easy, but when you do it, you can make huge, huge impacts.
Well, I'm sure we'll get more. So, Ron, you want to jump in?
Rich, let's start with you. Let's get right to it. Quite frankly, I'm going to quote you. I definitely want you to keep pushing the boundaries of science, and I think it's important to the medical industry. But when I look at the stats, and I'm sure you've looked at this, and I'm sure you can help us understand where it's going. If we just look at pharma costs today, makes up around 15%, give or take, of total healthcare costs. Given current trends, it'll probably hit around 27% in 10 years or so. What is changing in pharma that will allow you to continue investing in science, but at the same time, help us manage those costs?
Yeah, thank you, Ron. So I think one of the key points from the CHIA report is that, and we said this a couple of years ago, 1 year's worth of data does not a trend make. And the report from a couple of years ago, based on the 2014 data, which was very spiky, we said was quite aberrant. We shouldn't necessarily be making policies for 1 year's worth of data. And I think what we're seeing now, both in the CHIA report and also from statistics from Express Scripts and others, is that the spend on pharmaceuticals is slowing, is reverting back to the mean, and is generally back in line with overall healthcare inflation. So that's thing one. Having said that, I think to the chairman's request, none of us should rest easy. The answer isn't, therefore, we're done. There's a lot of other things I think that we can do that we can contribute. I think the first is an ounce of prevention is worth a pound of cure. And wellness and prevention is massively important given demography. Populations around the world are getting older and heavier and sicker, and no system is going to be able to withstand those demographics without thinking really differently about avoiding disease in the first place. This afternoon, we're announcing out at Longwood Medical a $75 million program with Brigham and Women's, MIT, and Astrazeneca, the American Heart Association, to try to figure out, using real-world evidence, how do we avoid and eradicate cardiovascular disease 10, 20 years before it hits you? So wellness and prevention is massively important and serious and something that we need to invest in, both public and private. I think the other trend line that's happening in pharmaceuticals is around precision medicine and personalized medicine. Over 90% of the drugs in our pipeline have a precision medicine component, a companion diagnostic. We're going to be able to be much more certain that the drug that you're taking, the drug you prescribe, the drug your payer is paying for, is going to be more probable to work for you, have fewer side effects, et cetera. That's going to increase the value of the drug you're taking, reduce side effects, increase its value. So personalized medicine, companion diagnostics is, I think, another major trend line that can be helpful. And then finally, I do think we need to keep our eyes open to moving from volume to value. How can we pay? With the two contracts, innovative contracts that we have with Pilgrim are about reimbursement based on outcomes and people being healthier. We have other kinds of contracts as well. If in oncology, if folks discontinue their medicines, if they change their treatment, we will reimburse them for the entire course of treatment up to that point. So we do think that these are complicated times. Managing costs in a world of increasing innovation is the task I think all policymakers have. But I think there are creative solutions we're beginning to see that can be accelerated.
Thank you. Want to jump in?
Go ahead. No, please.
No. So different topic, and I think a little more to Eric and Kevin. We've been talking on all of our panels throughout the 2 days about the adoption rates of alternative payment mechanisms, alternative payment models. And in the prior panel, I thought it was quite interesting to have Steve Strongwater talk about the fact that they're really seeing a decline in any kind of capitation, global payment kind of alternative models, and a slight shift toward more fee-for-service because of, in his, paraphrasing his words, because of the influence of national payers in this market and their unwillingness to go toward one of those models. I wonder if you two would comment on that, because that to me was, one, a revelation, and two, quite concerning in terms of the Commission's challenge to really speed the adoption of these alternative payment models.
Well, I'll start and then Eric can continue. I'd say we're seeing exactly the same things that Dr. Strongwater is seeing. So we're not seeing the acceleration towards the alternative payment models that we had honestly ourselves predicted would happen. And in some cases, we're seeing slippage backwards. And that's a real problem for us. This is the proverbial 1 foot on the bank and 1 foot in the canoe. It's probably the worst possible place to be for a provider, where we're in essence, some of our patients are reimbursed in some ways, other patients reimbursed in another way, but we treat all of these patients the same way. We're making investments to the tune of tens of millions of dollars in care management infrastructure to reduce those costs, and yet still living very much in a fee-for-service world, and that makes it very, very difficult for us. I think Dr. Strongwater addressed some of the reasons. Certainly, it's true that national payers have not moved in that direction. I don't think that's the only reason. I think that there are a host of barriers to increasing alternative payment mechanisms beyond the current levels. You're seeing, first of all, the level of complexity around these things. It's enormously administratively complex to add new components, to administer different ones with different requirements for a single provider. We've really got to simplify some of these things in order to get everybody on the same page.
Thanks, Kevin. Yes, I would agree on the national payer side. My experience with them, and having worked for 2 national carriers for 18 years, they seek national strategies, and simplicity and fee-for-service really does line up with that. It doesn't mean they're not making great exceptions, though, in pockets throughout the country, so I don't want to overgeneralize. But I do see more fee-for-service on the for-profit national perspective. From a Harvard-Pilgrim perspective, we believe that we've hit a concentration point, at least on the HMO point-of-service fully insured side of the house, where we're about 85% of our member months in a risk arrangement. We also believe that we've got work to do, still to do on the PPO side. We continue to find resistance on that. We have less of our membership in the PPO, so part of it is providers don't have as many Harvard-Pilgrim PPO lives in their panel, and then given how we sell, how the PPO product is sold, and you can go to any provider, there's resistance on their part, understandably so, but it's still something we're pushing to drive greater adoption within Harvard-Pilgrim on the PPO side. The other interesting piece that I would want to acknowledge, and I think this is a source of frustration certainly for providers, but also a source of opportunity, is that we've got a crack-up occurring of reimbursement strategies. On one hand, where we have full risk arrangements or with a provider system. As a payer, we're also incentivizing our members to pursue, in particular, outpatient high-cost diagnostics at more cost-effective, high-quality locations. And oftentimes, these are outside of the provider system that's receiving prepayment from us for their population. And it is frustrating for the provider, I would agree, but it also is a great way for the physicians who are referring to put pressure on their leadership to say, why are we charging $2,000 for this particular diagnostic when they can go down the road for a price much less than that? And when these are services subject to a high deductible, it comes right out of the pocket of the members, as you all know. So that's an interesting scenario that's occurring, and it's not an easy one for our academic centers that have to cover the cost of teaching and those types of things.
Please.
Just checking. Apparently, we don't look left.
So let me just follow up with that for a moment. Kind of given that all of the issues you each just elaborated, these plus out-of-network billing plus a number of these other factors are core to what the commission is working on. What could we do as a commission to either in the policy realm or kind of in the pilot study realm through our chart program, what kind of, if you use your imagination, what could we do to help you reverse this trend? Because it seems to me as much progress as we have made in bringing the cost growth curve down. There are a number of really important areas, from readmission to adoption of different payment models to post-acute care, where we are stalled. And so I would look to you to say, what could we do in this next year that would be most helpful, all four of you?
Well, certainly, Wendy, I would say that let's keep the spotlight on our performance. And that serves, in my view, a useful pressure to keep our energies focused on that.
Yeah, I would agree with that. I mean, I think that, I don't know if this is specifically what the Health Policy Commission could do, but I think that we've got to improve the design and the communication around alternative payment methods to, especially to self-insured employers. They're the ones, in essence, who are making these decisions, so that they incent employers ultimately to move away from the economic model of paying straight fee for service. They're the ones who will decide in the end. And we're not seeing as much of that change as we think needs to occur, and ultimately will be better for everybody when we get there.
Yeah, two comments. So we try to get these. We desperately want these APMs, and just a couple comments. So one is, I think this is hard for plans, and I think a lot of them don't have the infrastructure necessarily to maybe do this. And so pressure to have them move along this continuum is helpful. Number two is, I think that we often get everyone can't do these advance payments. We've got to go to the lowest common denominator. So I think having a range of options, so if people are willing to go all the way, let them. Number three is, in particular, there are a lot of, quote, APMs that are still based on a fee-for-service chassis, right? As long as you're billing fee-for-service, that means your docs are going to get paid on RVUs. It means that you're not really doing it. So having some versions of that are not based on fee-for-service going all the way. And then finally, what's really hard for us as a new entrant is often they've got rules that you need to have X thousand lives in order for us to give you an APM. Well, then you could never get there, right? And sort of, I think one of the problems in Massachusetts is there's a big lockup with big providers, and it's really hard for new entrants. I think if we want to make this system work, like in every other industry in the world, doing things that encourage new entrants to come in will actually make it better for everyone.
I think the Congressional Budget Office reported that for every dollar spent on Medicare beneficiaries that were adherent on their cardiovascular medicine saved $3 to $10 in downstream cost worth of value, including emergency room visits and inpatient hospitalization. So if we think about the CHIA report, Massachusetts stands in terms of hospital readmissions, you have to think about, are there ways we can increase continuity of care, adherence, make sure that patients are getting the care that they were prescribed so they're not coming back into the hospital.
Rashika, a question for you, and others may want to weigh in. So we've heard testimony for the past 2 days a lot about social determinants of health. And, everyone knows we need to go there, and we're having trouble pinning it down. You used the phrase in your opening remarks. Can you describe in a vivid way what it means for a clinician or provider or a team to get engaged with social determinants in your practice model?
Yeah, so I think we are able to ask the question so often. So the goal is not to save money in healthcare, right? Because if you think that's your goal, you'd end up doing shady things too often, because it's actually too easy to do, right? You just don't do stuff to people. We've seen that movie before. It doesn't end well. It's not even improve people's health. What you have to do is help them improve their life. That will improve their health. That will save money in healthcare, right? That's the whole chain. And you've got to be able to ask that question. And I think, unfortunately, this is the great quote from Anna Karenina that opens up, happy families are all alike, unhappy families are unhappy in their own way. This is not protocolizable. This is why you cannot use fee-for-service, say, we'll pay for this and not for that. You need to have empathetic, smart teams look at each patient and what is the barrier that is keeping them from improving their health. And it's things like, so we have deals where we can provide rides to people, right, when we're in full risk contracts, and often giving them a ride for a $7 partnership with Uber, and sending an Uber to their house to pick them up is a lot better than sending them to the ER for $10,000, right? I think we do crazy things. We have a story where we had a gentleman who was anxious and was going to dialysis. He was going to dialysis, but an anxiety disorder, so he would have to get up out of his chair. I'm feeling bad, get me out. And they would go into the hospital because he wasn't fully dialyzed. And the solution was buying him an iPod. And he would listen to his music and would calm him down in the chair. $35 iPod shuffle, saving tens or hundreds of thousands of dollars of costs, right? So it's being able to figure out what's the problem that we can solve with this patient and do it and do whatever it takes. And that requires, like I said, a different payment model, a different system, and a different way of thinking.
May I follow up on that? I am so intrigued with your model, and I love that it's based on relationships with patients and that you're trying to accomplish health and improving lives. So, but I don't understand exactly how you get paid, and especially how, now that you said you could save all this money, how are you demonstrating that so that you can reap the rewards? And can your model be, can it be brought to scale? Can it be enlarged across other payers or other systems, or even ACOs? I presume you don't belong to ACOs, so. And yet here we are focusing on ACO. So I'm just very curious if this is just a little island, or if it's a way to broaden your approach.
Yeah, so I started over saying we have to change the business model, right? And I think we decided we're going to just get on the canoe, right, and not sort of keep a foot on the dock. So all of our contracts are some version of global payment or just a very generous primary care capitation rate. So for instance, we have a contract with the Carpenters Union here in Boston. And they are progressive. They said this spending 5% of our healthcare on primary care, paying fee-for-service is a stupid thing to do. So we're going to pay you a fixed amount and double down on the primary care, give you 10%. And then what we expect is when you lower the hospitalizations and the ER visits, we're going to benefit from it. And that is proven out. We do that with Dartmouth College, with a number of employers. On the Medicare space, we've moved into really taking global risk, percentage of premium, where essentially we said, we're confident enough this works. Tell you what, the plan keeps a percentage of the premium, the rest of it's our money. So we draw down an amount to pay for our primary care, which again is double typical primary care because we think that's the right answer. And now when we lower hospitalization and ER visits, that's our money. We can reinvest that back in primary care. Right, what we've done is change the cycle. So we're in this vicious cycle right now where primary care, the front end of the system, is underinvested in. So you end up doing 7-minute visits on patients and not having support. And then people end up in trouble and end up in the hospital. In the ER, healthcare costs go up. And what do the payers do? They ratchet down on the payments. And now you've got 6-minute visits, right? So that cycle's going the wrong way. So we said, let's actually change the cycle and turn it the other way. So let's double down on primary care, invest in health coaches and technology and Uber rides and all the other, all the other things we do. That will actually keep people out of trouble. That will lower healthcare costs. We will capture some of that value. We'll invest more in primary care. Now we'll add something more in, right? So you turn the cycle the other way. So is it scalable? Why not? Again, we're doing this in 24 practices, 8 different markets. We're doubling in size in terms of patients each year. We're not the only ones doing this. There's a small but growing number of us doing it. I think the key is you have to just do it, right? And the thing we're pretending in ACOs is that we can do both at the same time in the same practice. I think that's a fool's errand, right? Trying to do both is, if we want to do this, let's set it over here and try and do it this the right way, and eventually we'll move the market, right? But I think our big advantage is we simply decided we want to do this.
I can't help mentioning the iPod Shuffle tells your real answer is an apple a day.
Don, can let me lend a payer's perspective and not on the Apple joke. I love what Ruchika is doing, and I think that is exciting and the right direction to go, and I'm glad you're bringing this up. One area where our state has not done well, and we still need and have a lot of work to do, is in healthcare disparities. And averages cover a lot of ills, and until we're able to say that we cannot determine the health status of an individual by their zip code, we have a lot of work to do. And I think social determinants of care is related to that and will help put better focus on where we should be putting our efforts. Just as an example, up in New Hampshire, where we are in one of the states of New England, we established a joint venture and a new business with Dartmouth-Hitchcock and a number of other health systems, and we created a population-based company. You're probably familiar with it, Benevera. And what we're doing at Benevera is we're blending together electronic health record information and financial claims data. And this is where we all need to go within our healthcare system. And the simplicity and the power of bringing these two together as a combined information set is really rather remarkable. I bring this up in connection to your question because I think it helps us to move in the direction where Ruchika is heading, or is, because it provides the employees of Benevera, who are both provider and payer focused, to sit down and use this combined data set and then provide this to the clinicians to figure out of their population what's going on, how can we best put our focus, and how can we best produce better outcomes, lower medical cost trends, et cetera. It's made a big difference in the first year. We've seen a double-digit difference in the year-over-year medical cost trend for populations that are supported by Benevera versus those that are not. But I believe there's also value in this combined data set as we tie in social determinants of care, because that's a missing piece to produce even better outcomes and get care, frankly, to those that need it.
Can I just, I'm fascinated with what Iora Health is doing. And as you point out, there are a number of folks out there doing similar things. And I think that there's a lot for those of us that have been around for 100 to 120 years to learn from new innovative practices like theirs. That being said, I think the question that you asked, Dr. Allen, about whether this is scalable or not is a really good question, and I don't think that we know the answer to that question yet. We're experimenting ourselves with pockets of doing innovative things like they are doing. But we don't have the luxury of picking and choosing where we put our practices or what sorts of services we provide or which populations we will serve. We serve all of the populations that come to us, and we provide all of the services that they need. And that doesn't necessarily lend itself to the same model that folks like Iora Health are able to choose. So I think there's a lot we can learn from, but I don't know whether that's going to be scalable across a large system or across the entire country. We'll see.
But you could invest more in primary care as a start. That might be one way to.
We absolutely could, and we do invest a huge amount in primary care. The key to getting systems like ours to invest in primary care is the simple realization that it benefits everybody. It benefits patients. It also benefits the system. I think we're pretty aware of the fact that when we make investments in primary care, our patients will be better for it, but our system will also be better for it. So we make significant investments not just because we think that that's morally and ethically the right thing to do, although we do. We do that also because we think it's good business.
I want to change and discuss something that I don't think we've ever discussed, but I think it's very important here in Massachusetts. And it also gets to what Richard was talking about before. We do a lot of things so much better than other parts of the country. And I don't say this as a but, and I would also put this as a positive but negative. One of the areas that separates Massachusetts from every other state is the fact that we use our teaching hospitals disproportionately more than any other part of the country. Dr. Slavin yesterday, who I have a lot of respect for, and I'm really glad that he said something which I believe for a long time. He basically said, and I think everyone here heard him, he said, we and academic medical centers need to be paid more than community hospitals and primary care because we need to take the extra money from clinical care to subsidize research and education. Now, I want to make it very clear, I'm supportive of research. I happen to be at Brandeis University, and we just won the Nobel Prize. I just want everyone to know that. And I take personal responsibility for it. So, right, the royal we. Hey, listen, we get banged around a few times. So I want to get back to this. I do believe, and that it's not a question of whether I believe or not. There's no question about it that our academic centers do subsidize research and education, and both research and education are valuable additions. The question is how much, who decides, and what do we do about it? And do we justify any differential between an academic center or any differential between what the price of a drug company charges because they claim that they're going to use the money for research? Or are there limits, and how do we figure that out? That is the area that no one really has focused on. It's all well and good to focus on making our delivery system and primary care more efficient and worrying about, as I do very much, on all the behavioral aspects. But that is a very important issue that has really not been discussed. Kevin, I know you're in the middle of that. You're both an academic center. You do a lot of good primary care. How do we deal with that?
It's a good question. The classic tripartite mission of an academic medical center is to provide great clinical care, to generate new knowledge, to do research, and to educate the next generation of clinicians. I'd actually say that talking about a tripartite mission of an academic medical center misses out. I think we've got at least 4 missions. So in addition to those 3, we also provide a disproportionate amount of care to the underserved. We always have, and we always will. The challenge, as you yourself have just pointed out, is that at least 3 of those 4 missions lose money. They don't make money. And so they have to be paid for in some way. It is more than fair and legitimate to say, okay, they need to be paid for in some way, but that doesn't give you carte blanche to charge whatever you want and that there is no limit to that. I think that needs to be a two-way discussion. Is that important to the Commonwealth? I believe it is important, but what's the limit? Because by paying anything, by paying as much as people demand, obviously we're making trade-offs. And we are therefore saying we're not going to invest in other things, whether that's invest in community hospitals, invest in primary care, whether that's investing in health and wellness, or whether that's investing in things that have nothing to do with healthcare. So what I say to our own employees when we talk about reducing costs is, I show the slide of the increase in costs of healthcare in this state, what the state spends on healthcare. And I ask people, how much do you think we're increasing in education and in public safety and other things? And people will say, well, it must be a much smaller amount. Well, it's not a much smaller amount. It's negative numbers. There's only one box of funds. I think we all recognize that. And we're making choices by paying as much as we do. We need to continue that two-way discussion about how much is enough. I agree.
Richard, you want to, I mean, this is the same thing we keep hearing, and I'm not saying you alone, but everybody in the industry is, well, we need the money because we need to invest in research. Where, are there limits to this, and where is that balance?
So I think you can look at it a number of different ways. So one is the pharmaceutical industry. The research-based pharmaceutical industry returns a higher percentage of sales to R&D than any other sector. It's about 20% on average. Astrazeneca is the highest within our sector. We're about 28% of sales back into R&D, which adds up to, as I mentioned, nearly $6 billion in R&D last year. And the results are astonishing in some therapeutic areas. We're entering this era of immuno-oncology. We presented at a number of medical congresses this summer in our respiratory pipeline using the cure word for certain kinds of respiratory diseases. And so you also have to go back to the other mega trend I mentioned earlier, which is the burden of disease in the world is growing. And we do need to think, we're not going to solve it with more doctors and more hospitals or fine-tuning our systems. We need to have truly innovative, game-changing solutions to get ahead of some of these global trends. It takes us back to the conversation we're having today. And I don't think it's how much research is enough or how much R&D is enough, because I guess only if there is a pill for something that you are sick of are you able to say, yeah, we're good. But that's not the case for 99% of the population. I think it's really how do we balance it? How do we pay for it? How do we finance it? But I don't think it's necessarily wise to think about, yeah, we're there.
Yeah, so, in the day when healthcare was essentially paid for by the government or by profitable big employers, and they chose to spend some of that money essentially to subsidize research and education, that's fine. The problem is almost all of our patients now on the commercial side are increasingly on high deductible plans. So what we're asking are individuals who are often low income to take money out of their pocket to subsidize these things. And I think that's a big, big problem. And from our point of view as sort of stewards of our patients' money, it is almost impossible to justify spending 3 times the market rate to get a commodity test like an MRI or a Chem 20 in a place like that. But that's a big problem for them because that's where the business model's made. And I think as the trend works, as consumers increasingly take control and people like us help them. By the way, it's almost impossible to figure this out as a consumer because we hide the prices, but that's game's over soon. I think it's going to be a big problem that this stuff does need to get paid for, but relying on the consumer to pay it is not a good idea.
Well, part of the problem is the greater Boston area doesn't really have a secondary general acute care hospital. Everything is teaching there, and we need a lower cost facility. And I would also say that academic centers should be paid more for the services that they provide to support the teaching, but not the degree that unit costs and total medical expense evidence shows today. It's supported by brand. And frankly, it's supported by a lack of transparency and quality. Most consumers think the downtown teaching hospitals provide the best quality care, but we know that's not the case in all cases. But until we provide decent quality, comparative quality data for consumers that's useful, easily accessible, we won't be able to show them, and they'll think it's all about a price game, and we're trying to drive them away from the best. The other area, and I think this is an area where the Health Policy Commission should focus their attention, is we have these systems of hospitals and physicians that are out there, but they have a long way to go in showing their value and shifting care to lower cost facilities or outpatient or even at home. It's not easy to do, I acknowledge that, but that would be one of the challenges I'd say to my friend Kevin. How can you shift more and more of the volume out of the high-cost facilities? It's just not happening. Enough.
Yeah, and then Ron.
Thank you. I'd like to take a more macro point of view. Last year, we beat the benchmark, which was good. The issue that I see, and I'm really interested in your opinion on this, is we beat it when the inflation rate in the U.S. was at around 1%. If we go back historically to the early 60s, late 50s, healthcare has always risen more than 2 times the U.S. inflation rate. Are we going to be able to stay below the established benchmark, or as inflation gets back up to a normal rate close to 3%, what's going to happen to healthcare costs?
So let me have a great question, Ron. Thank you. And I'm going to go back to the question I think you raised right in the beginning. I'm very concerned about the upward pressure on pricing with the newest drugs that are coming out. And I think we've made good progress in slowing that trend, but I think the train is coming down the track on these new, wonderful technologies that are saving lives or improving lives like we never thought we could. The first gene therapy is coming out very soon. It's being produced by a local organization, and it's for blindness. And the price has not been set, but what we're hearing is the price for a dose per patient, it's a intraocular injection, is somewhere between $1 million and $1.5 million. Now, what is a definition of an orphan disease? Somewhere around 5 to 7% of the population. So take 5% of 1 million lives. We're about 1.3 million lives now, but if round numbers, 5% of 1 million lives is what? 50,000 people taking a drug that's $1 million. And this is just one of the newest therapies that are coming out. So my point here is that we've had specialty drugs, and it's very common to go 75,000, 300,000. I'm concerned that the gene therapies coming out and these new CAR T drugs, which are incredible, are in the millions. And the insurance model doesn't support it. And I also believe it will cause this upward pressure on our year-over-year trend, even if the general inflation remains steady. So I worry about that one. That keeps me up at night.
You know, I share Eric's worry, and I share your concern that we will see an increase again in costs. I think there's a lot of work that went into bringing it down to 2.8%, but you're right, it is no guarantee, especially as if inflation heats up, that we won't see rises. I'd say in spite of all of the work that was done to control costs, as Eric points out, especially the explosive growth of the cost of pharmaceuticals has been a real challenge for us. So the inflation rate for pharmaceuticals in our organization, even with all of the cost control mechanisms that we have in place, and we have a lot of cost control mechanisms in place, is nearly 8%. I mean, that far outstrips almost anything else that we're looking at, and that is a huge, huge challenge for us.
All right, Don, you wanted to say something, I know?
Yeah, yes. This is more detailed than these larger comments from me, but we're pursuing in the commission the idea of moving care to community hospitals from appropriate care to community hospitals. We defined a set of conditions that can be cared for in community hospitals safely. We're not making progress. The trends have been neutral or negative, so that more and more of the conditions that could be cared for in community hospitals are being cared for in teaching hospitals. That's rising. So I'm interested, especially you, Kevin. I'm sorry you're the only teaching hospital representative there. Yeah. I want on my tombstone. I'd like something called Berwick's test, which is that we'll know we've successfully reformed healthcare when hospitals try to be empty, not full.
Hospitals try to be empty. Yeah.
You like the
I
ring?
appreciate it.
How do you view this goal? Can you make your business model work that way? Or I assume the answer is yeah. Keep your beds full with higher tech patients. But just talk a bit about that goal and your attitude toward it.
Well, I appreciate what you want written on your tombstone. I when I was out at Stanford, I was frequently asked, because Kaiser was right up the road, and I was chief medical officer there, and I was asked, well, what's the big difference between your job and the job and what they do up at Kaiser? Why don't you just do the same thing? And the way that I'd simply explain it is that every day, 3 times a day, I would get a census report. 365 days a year, I'd get a census report every 8 hours. And my counterpart up at Kaiser, every day, 3 times a day, would get a census report. And the fuller we were, the happier I was. And she got the same census report that I did, and the emptier they were, the happier she was. So, I mean, I think that supports your point. And those are 2 very, very different systems that are designed very differently. I don't think we should be surprised with sort of where we're at, given the way that the system is designed. I share the concern that you have and that the Commission has that we're not doing enough to move care when appropriate to community hospitals. I would suggest, first of all, that any CEO, starting with myself, that any hospital CEO that sits here and says to you, oh yes, we really want to move care to lower cost sites of service, that doesn't have lower cost sites of service probably is going to struggle to do that. I mean, it's just basic economics. And so I think that one of the things that we have been doing is to make sure that we have lower cost sites of service within our network so that we can shift that care and not simply put that as a bullet point on a PowerPoint presentation. I think I don't yet know enough about the metric that you're referring to, and I look forward to digging into understanding more. I have no question that there is more work that we could do. So before we even dig in, I'll admit that we've got more work that we can do. That being said, in our own system, I mean, where I'm a little surprised is I'd say the metrics that we look at, admittedly different than yours, in our own system, we've seen a significant increase in volume, in patient volume at the community hospitals that are member institutions over the last few years. When we look at the Mass Hospital Association data, between 2012 and 2016, BID Needham's gone up 26%, Milton 18%, and Plymouth 9%. In the last year, we've seen 8.1% increase in hospitalizations at Plymouth, while in FY17 at the medical center, even though the patients utilizing our hospital are with higher acuity and increasingly complex, we've seen hospitalizations that are flat to slightly declining. That's what we should see. That's the point of having a system like that. So I'd like to better understand the metrics that you're looking at, but I would say that we have evidence that we are making some progress in that direction, and we've got a lot more work to do.
Marty?
I want to switch gears a little bit. We had the pleasure of the last 2 days of hearing from the governor, the Senate president, and the Speaker of the House, all 3 looking at significant changes in health policy, health regulation, insurance regulation. I'm curious if we went down, as the Senate president talked about drafting a bill within the next month, what would you want to see in that legislation that you believe would allow us to continue the trend we're on in terms of cost containment?
I think all of you.
All right, thank you, Marty, for the question. To no surprise, one of the areas that I would say I hope we have legislation passed to help deal with runaway pricing on certain pharmaceuticals is to create some mechanism for greater transparency on those actors that are abusing the system. And just to point it out, related to that, I am a big believer in establishing, and I think this commission could do it, take advantage of an organization such as ICER that will look at the clinical effectiveness of a new medicine that comes out, and to begin establishing a benchmark that's very publicly available and comparative because we are seeing medicines that are not producing the kinds of savings they're touted to be. And frankly, I think there may be some medicines out there that deserve a higher price than what they're earning right now. So mine is around pharmacy pricing, greater transparency of year-over-year change, and a mechanism to create a scientific, clinical, research-based method for a comparative clinical effectiveness.
Yeah, I was just going to weigh in. I think I wasn't sure. I couldn't quite reconcile your first sentence with your second when you said some of the runaway bad actors, or if that was tied into the ICER comments. I do think if you were referring to the Martin Shkreli's of the world and the Turing Pharmaceuticals of the world, we're with you, right? We don't really consider those research-based pharmaceutical companies. It's more like a private equity shop in sheep's clothing. That to me is a separate issue and raises different policy questions. I think when it comes to ICER or some kind of bodies that are looking at clinical effectiveness, again, we're a science-led company and a science-led industry. We're not afraid of data. We're not afraid of these kinds of reviews. We're always want to make sure, however, that whoever is doing the reviews, that whoever's sitting on those committees are representing not just the cost of the pharmaceuticals, but also representing the patient view and the impact on patient health as well as the bottom line. But beyond that, we're okay with general clinical reviews. And just to your earlier comment, I have a hard time also reconciling why things are statistically so different with Beth Israel than the rest of the norms, where it seems like no matter how you slice and dice the data, pharmaceuticals are 10 to 15% of overall healthcare dollar. If you look back 20 years, if you look forward 20 years, I know it can be different in different institutions, and I can't account for that with you, but I also think that it's also difficult for policymakers to try to come up with policies that can solve for, maybe a specific or a micro problem that exists in some institutions. I think if that 15% of your healthcare dollar is what's fueling the innovation for, again, game-changing innovation that at one time we thought the AIDS medicines were going to sink the healthcare system. And we thought the oncology medicines were going to sink the healthcare system, and then the Hep C was going to sink the healthcare system. I think if these drugs are truly effective, if there's truly value, then patients and providers and the industry find a way to pay for it, to pay for that innovation. And that's a pretty good return on 15% of your healthcare dollar.
The other two want to answer?
I'd say, as it relates to legislation, I think that there's a place for addressing some of the. It's been pretty well documented that the marketplace here in Massachusetts is not functioning in an optimal fashion. And I think that there have been attempts at dealing with that from a legislative perspective, and I think that there is a place for the legislature to consider some of those issues. I would actually also agree, though, that it's be careful what you wish for, and that legislation frequently has unintended consequences. And it certainly would be true that legislation alone will not address this issue unless we were to move to a single payer here, which I don't think is going to happen. And so I'd say we really need to make sure that we allow for market-based solutions in addition to any legislation that comes up that will address the dysfunction that exists in this market. And that's one of the things we're thinking about a lot.
Rashika?
Yeah, so completely agree on the price transparency piece, and it's not just on pharmaceuticals, right? It's also on downstream services. I think there have been attempts, but they're weak, to be honest. And I think particularly if we expect consumers to pay these prices, they need to know the real price. And we keep making excuses why we can't do that. In any other industry, it would be unheard of that consumers are expected to undergo things and not know the exact number they're going to pay. right? So you go to a restaurant, menu, we expect the price on it, right? So I think price transparency really matters, particularly in an age where consumers are more and more expected to pick up the bill. I think, whatever can be done to, encourage payers to move to real advanced payment models would be helpful. And the third one, this may be a little controversial, is I think strong independent primary care is a really important part of the system. We've evolved into a place here in Massachusetts where virtually every primary care doc is owned or in a network with one of the big health systems. And I don't think that's really good for the Commonwealth, to be quite honest. And I think there are a lot of features that lock people in. It makes it almost impossible for independent primary care to exist in Massachusetts anymore, and I think it would be good for the state if we address that.
Did you want to say something?
Yeah. Thanks. Right behind, just following up on the cost trends report, pharmaceuticals clear was the top one. Right behind that was out of outpatient services as well as other professional services, which I think captures long-term services and supports. So wondering what your thoughts are, what's driving that? Is that good or bad spending? Does that impact your ability to coordinate the care of those patients or individuals? And then what, if anything, do you think the HPC should be looking at to better understand what's driving those changes?
I think, we are, first of all, we're seeing a more and more of a trend from inpatient to outpatient, and that is a good thing, not a bad thing. Over time, we need to see a drive from inpatient to outpatient to home, and then over a time, a drive from inpatient to outpatient to home to wellness and prevention. And we've not gotten that far down the path. I think it's a natural evolution. If you were to talk to a healthcare system 5 years ago and say, what's the primary driver? Where does your revenue come from? It was almost all inpatient. That's no longer true. That's moved to outpatient. And again, I think that's appropriate. That's where medicine's going. So it's not a surprise that grows. We've got to see the other side of it shrink as that grows.
Tim, I would say two things. One, we are seeing some shift, not nearly enough, from inpatient to outpatient, and that's good as a lower cost site of service. What we have seen a spike in, and it's a curious hypothesis. I think with the systems moving to electronic medical records, they're much better positioned to code more effectively. Yeah. Much better. And, frankly, if I was on that side, I would be too. In fact, they're hiring consultants to figure out how to increase their revenues, and we're hiring the same consultants to figure out how to control them when we're processing the claims, and that's no lie. So it's a consultant's fault. But let me just give you one fact here. We conducted an audit of provider coding patterns for emergency department services, and the result of this over a period of a year showed that more than 28% of physician emergency department claims and almost 20% of facility emergency department claims should not have been reimbursed as emergency department services, but rather as office visits. So we're doing a better job of monitoring the coding and the patient records and all of that. But this is, it's over the decades I've been in this, you have a push on the revenue side from providers, the payers figure it out, and then they put something in their claim system. This has been an area of spike. I think we need to monitor, we certainly are at Harvard Pilgrim, but monitor much more closely the appropriateness of coding on the emergency department side.
Well, I'm going to need to bring this to a close. I really want to thank all of you. I mean, this was extremely helpful. I appreciate the time that you've spent joining us, and we may be asking you to come back next year because we learn a lot, and hopefully you'll keep at it. Again, as I said before, we've been making progress, but we need you, all of you, in your own worlds to keep at it. And as several of us have said, it's all well and good for all these nice, good things we're doing, but we are sort of running out of money. So thank you so much for coming.
Thank you.
Nice to meet you.
So we're going to enter into a different format for the next 40 minutes or so and have a discussion among us as commissioners. What have we learned in this? What are the themes that have come out of these 2 days and areas that we, in fact, can move forward in and making changes. And I really want to appreciate the questions that we've gotten from a number of you, both in both areas, in terms of moving the ball forward, but doing it in a responsible way. So does anybody want to get us going? What do you, Don, would you like to join, start? What do you think?
Summary of takeaways?
Yeah, some of the takeaways that we got.
I thought the conversations were very rich, Stuart. There were 4 takeaways I was just making notes of as we got ready for the session, in no particular order. I am impressed by the potential of global payment, of more consolidated payment. The progressive providers and almost everybody thinks that they could do better in that environment, and yet the data show we're going not in that direction. I think that's something we need to dig into more. It's a contextual foundation for a lot of what this commission is supposed to try to help accomplish. The second is the details we got into around metrics and goals. If I understand where the commission's headed, we're now going to be picking up on a subset of levers for safe cost containment, where costs will go down and quality go up. The one we dug into the most here was the readmission metric. There's also the one about movement of patients to community services. What I think I discovered here is that we do not have an agreement among the stakeholders either on the goal itself and equally important on how we'll measure the goal. That came through most clearly in the conversation about the movement to community hospitals. That's a formula for confusion and waste of time. And I think we have some work to do here to come together so that the payers, providers, and public and the commission agree on what we're going to try to accomplish in that area and on the metric to do it. I thought it was interesting, Kevin, in his very last comment, said he wasn't aware of the metric about the community hospital appropriateness. We've got to get over that. The third is the repeated theme of social determinants. We heard from the first panel and then repeatedly through other panels, everyone kind of agrees we need to put some meaning behind the idea of working on social determinants, and yet we don't have it. It's very vague, and I think we stand to gain a lot as a commission by deepening our exploration as to what it means for healthcare to be involved in trying to affect social determinants of health. We can say more about that. The last piece is pharma. And I guess there we don't have a solution. I mean, we have a problem and no solution. And I think it's a very, very hard problem which we need to tackle. I'm not sure we can get costs in the Commonwealth on the right trajectory without much more creative approaches to pharma pricing than we have right now, and we're still not there. So those are a few takeaways, Stuart.
Okay. Others want to join in?
I'll jump in.
Tim?
I mean, I agree with a lot of what Dr. Burke had to say. I guess for me, kind of obvious, but keeping an eye towards the federal government and the policy changes that are happening there and its impact it could have on the great progress we've made here, that we got to stay focused on that, and that all the gains we've made could be wiped out with some action that we otherwise don't control. So I think that would be something that was reinforced for me during these hearings, and it came out time and time again. And I would say want to reinforce what I stated on that issue is also not just healthcare policy, but our immigration policy, its impact on the workforce currently. I've heard from many of our employers in the long-term care setting and home care setting that it's really having an impact on the workforce. And we heard from the state auditor around the need for more healthcare workers in this Commonwealth, which is a good thing. I think the report that was talked about, the Commonwealth Corporations review of the workforce was a good thing. It said that we haven't lost a lot of healthcare jobs. In fact, we need more healthcare workers. So I thought that was interesting. But also the immigration policy and potentially its impact on undocumented and in some cases documented immigrants not seeking care, and what impact that will have on our overall healthcare system, because I'm sure there's people that would otherwise be seeking care that are not now out of fear. So I think that was something I took away. Secondly, and again, something we knew going in, it's an exciting moment to have the legislature yet again taking up a significant healthcare bill. And I think the testimony here today and our deliberations and the reports of CHIA and the HPC are going to have hopefully a bit of impact on that debate. Hopefully they're seeking the opinions of the folks that have done the research and understand what's happening in this Commonwealth are going to have a great influence on that debate and discussion. So that's exciting news, and see what direction they take around some of the issues that have been raised here today and that we've raised through our deliberations over the past year or so, and longer for many of us. This is my 1-year anniversary of being on the commission. And I agree, Don, wholeheartedly on the metrics. I mean, I think it's important to make sure we're all in agreement of what we're trying to measure so we can see if we are making progress or not. And also what came out again, which I wasn't expecting, was a lot of references to the Price Commission, the Price Variation Commission, and the work that was put into that. And we heard from many hospitals, in particular, the low commercial insurance rates for community hospitals are really having a big impact on their ability to deal with all of the social determinants of health and all the other issues that have been raised. So it was intriguing to me that that came up a number of times, both in the testimony, but also referenced by the Speaker and the Senate President as a report they want to take into consideration for the deliberations. So I think I look forward to that debate and discussion. And just I wanted to thank the HPC staff for all the great work in putting this on and for having it only be a day and a half. Thanks.
Thank you. So, yeah, the staff, you deserve a lot of applause for all of your work. I was, last year when we talked about social determinants, I was feeling great that we were starting to talk about it. And this year, it was pervasive throughout the entire 2 days. And I'm so glad that we're finally talking a little bit about root causes of health issues. Another way I've heard social determinants described is essential health needs. So it is, to think about it in that way may refocus us a little bit on these are needs that our population has in the health realm, and how do we address them. I was impressed that some of the providers who are in fact doing some of the work around those areas in the community, trying to address things like transportation and other housing even, and nutrition, are the ones who are struggling the most and have the fewest resources to accomplish what they need to do. And I feel like there's an opportunity for us to start talking about the bigger, we also talked about, Mary Lou talked about silos. I think that we need to, and I've heard somebody say a public dollar saved is a public dollar saved. So we need to think about some of these dollars are our public dollars, and should what we haven't talked about is what rightfully belongs in the medical realm. And does spending on something like housing or food security or something like that belong in the medical realm, and should we be looking in those directions? So that's sort of where I'd like to see us going forward, or at least the commission going forward. But I think that we're starting to go down that road to really think about what are the drivers and how do we address them and move that conversation forward. So that was very gratifying.
So two things that sort of emerged for me as opportunities for us these next several years. One is this multifaceted issue of shifting care. And I heard it in several different ways. One is the issue of we're not being successful in shifting care from academic medical centers to community hospitals or other sites of care. Including decreasing the use of post-acute care when it's not necessary. The second piece that was interesting that I think Steve Strongwater talked about was shifting care not in place but in person. That we really have an opportunity in this idea of working with the legislature to get regulations to allow people to work to the top of their license. And when, many of you may not know that he was at Geisinger and really was an extraordinary innovator in doing exactly what he used as an example, and that is putting nurses in emergency departments so that people who didn't need to be there got appropriate care. So kind of the concept for the commission of looking at how do we shift care in terms of both place and person being the caregiver. The second thing that is still disturbing to me that I think we really have a number of opportunities is what people described as the slippage in moving from alternative payment models back to fee-for-service. And some people were able to identify the barriers to speeding the adoption of alternative payment models. Others seemed kind of puzzled about it. But the fact that both payers and providers feel strongly that alternative payment models are not getting the traction that we all had hoped they would, I think gives us an opportunity to think creatively, how can we help move this forward? Because if you know that Rushika's model may be somewhat utopian, certainly he's able to accomplish what he has done by shifting the payment paradigm.
So I would ditto what Wendy said about shifting care. And if I go back to what the purpose is of the Health Policy Commission, it's about reducing healthcare costs and improving quality of patient care. And shifting care is about the readmissions. It's about the use of nursing home, post-acute care, people operating at the top of their licenses. And I think that could be a theme that draws together several years of cost trend hearings into something for the commission. Perhaps I'm just a little tired after a day and a half. So quite honestly, maybe I'm just a little cynical. With the exception of Rushika, I heard people toss out the term social determinants, and I'm taking the public officials out of my comments. It's really about the people who are on the panels. So it's not towards the Attorney General or the Governor or the Senate President or the Speaker. But I heard people toss out the term social determinants. With the exception of Rushika, he was the only one who actually offered examples of how they were addressing it. So quite honestly, to the members of the commission, I feel it was a throwaway and a way to actually distract us from some of the other things we were putting on the table. Like I said, call me cynical at this point at the moment.
Maybe hungry.
Maybe hungry.
Angry.
No. Behavioral health, and quite frankly, I'm really tired of people talking to me about integrating behavioral and physical health care without really concrete examples of what people are doing. We heard a little bit, so I'm pleased about some of that, but it's expensive, and one of the things we've done is we've suppressed rates. We don't mind if people board up in emergency rooms. We wouldn't do it if your family member had cancer. You wouldn't tolerate them being in an emergency room for that long. We've done a lot this past year to bring down ED boarding, primarily in the public sector space, quite frankly. The access to care is not great. The outcomes are really bad if you're a person with serious mental illness, so you're going to die. People have heard me say this before. So you're going to die 25 years younger than your non-disabled counterpart, and you're going to die from an untreated, uncomplicated medical disease, stuff that probably nobody in this room is going to die of. And if you add addictions on top of it, take another 10 years off their life. So we just took 35 years off of somebody's life. And so if the Health Policy Commission really wanted to start to land in the space, I think we really need to push this and continue to push it. We're going to do that in the Commonwealth, but I think we have an obligation to the 1 in 4 people who have a mental health condition or a behavioral health condition. And finally, I guess I would slightly disagree with Dr. Berwick. I think there is actually a lot going on around metrics in the Commonwealth of Massachusetts. The Health Policy Commission just has a small voice in that. And in fact, one of the panelists mentioned that. And part of it is for all of us coming together of what those key ones are. But I think there's actually much more alignment on that than what perhaps a few people on a panel suggested today. So that's sort of my takeaway at the moment.
Marty?
It's hard to go at the end here. I would echo the Secretary's remarks. I think we heard loud and clear throughout both days about behavioral health as a driver. healthcare costs and of sort of ineffective care management, but yet the promise of fully integrated behavioral health and physical health care still eludes us for some reason. And we haven't really talked about the sort of community outpatient capacity in the behavioral health field, which we know means 8 to 12-week waits for outpatient appointments. So there's a whole side of that equation that we haven't even begun to look at. I would also agree. I think other than hearing about an Uber ride, the opportunity to invest in social determinants of health is still something out there, and it isn't grounded in the work that folks are really doing on a day-to-day basis. I will say, we also heard about the potential of the Mass Health ACO, and I give the secretary and her staff credit for that. I think there's a lot riding on that, and rightfully so, but I think there's a great opportunity there, particularly as we think about state dollars being expended for healthcare. Finally, I will say, the whole discussion around alternative payments always came back to the chassis and that it's a fee-for-service chassis. Well, it's time to retool because I think that chassis in and of itself is preventing us from doing some of the other things that we really want to accomplish. So whatever we can do to begin to think about the retooling of the chassis to allow alternative payment methodologies to be able to fund some of these other things, I think will help us in the long run. I just also want to, as Tim did, commend the commission and David and your staff. I thought the panels were terrific, and I know a lot goes into these 2 days, and wonderful job on behalf of everybody.
I think I'm last.
I think you will.
Oh, okay. Well, there's not much more to add, but again, commission staff, great job. What I took away was, and I look at the issues, whether it's behavioral health or moving to the community, as an economic problem. Even the chassis issue. If you came to my business and said, you're going to put more dollars on the bottom line if you change your pricing, mode of pricing, we'd do it overnight. So the question becomes, when we look at moving to the community, if they move to the community, are they going to make less money or more money? That's a reality. We got to really look at that, right? When we look at 8 to 10 week wait for appointments in behavioral health, I'm willing to guess, I'm not from the hospital industry, I'm willing to guess their margins are very slim in that area. So when we look at what we're trying to do in terms of managing costs, I think we really have to look at the economics. And what can we do as a commission advising the state in terms of actions they need to take so that these firms, and I will call them that, they may be nonprofit, but the reality is businesses are in business to generate margin. I'm in business. I want more market share. I want more margin. And they're in that same boat. And I think we really need to look at it that way. Right? Do I think we should be moving to the community? Sure. First of all, convince me that I should go to the community hospital instead of going downtown. Right? I think that's a decision we as patients need to make. Right? But the stats we have support it. Those stats need to be made available to people who need medical services. And as long as we don't have those stats, I'm reading U.S. News and World Report, I have to go into Boston, regardless of what the issue is. Although, would I prefer to go locally? You bet I would. So we have work to do from a transparency standpoint as well. We talk about it a lot. And it was brought up several times over the last couple of days. But that's really an area we need to look at, both from a cost perspective and a quality perspective. And again, thank you to the commission staff. You guys did a great job.
Yeah, well, these are really, I was listening to, and I actually took notes about all the different areas. But I want to talk about something different, which is really what didn't come up in the discussion, but it keeps running in my mind. So here we have these two forces. On the one hand, we spend an awful lot of our income on healthcare. As the Speaker and the Senate President and the Governor said, 40% of our state budget is going for mass health. And we heard from Rashika that increasingly we're asking individuals to pay a substantial amount of their health care. Our business community now is finding they can't support it. So on the one hand, we're spending an incredible amount of our income on health care, and the idea that we can continue business as usual is grinding to a halt very quickly. Yes, we've improved. So we're no longer the most expensive, the state of Alaska. Come on. We're still the most expensive, although I really take pride in the fact that we were a third or fourth lowest in terms of rate of growth. But on the one side, we're spending more, we're spending too much, and it's just eating us up. On the other, we hear, and rightly so, that we need to reallocate money and spend more in areas like social determinants and behavioral health. So we got a double problem. What I don't hear is really fundamentally changing the healthcare system. This is still a gigantic delivery system. Don, you raised the issue about your tombstone. The problem is that these hospitals are the largest employers in their community. They employ large numbers of people. And the idea is basically, if we're going to spend less, we have to reduce the size of our healthcare system, the people that work in it, the structure of it, and then reallocate some of that money to areas that are not getting enough. But we need to do it in a kind of a sensible, orderly way because, these are people's lives. So I like what we're doing. I think that our rate of growth is slowing without it being drastically cut. But what we have not seen, and we pointed it out, that we have not seen a movement from the teaching hospitals to the community hospitals. We've really not seen fundamental changes in our payment system. We've really not seen us using less high-priced pharmaceuticals. And yeah, I'm the first one to pop a pill, if it promises to keep me alive for another 20 years. But the idea, $1 million or $1.5 million a shot, these are just high numbers. So what troubles me is trying to see the healthcare system slowly change and really reduce its footprint and redirect it in an orderly way that allows, the shifting of the dollars to the areas that we know we're not spending enough on, whether it's social determinants or behavioral health or primary care, but to do it in a way that doesn't lead to what I think is going to be a real pushback. Several people came to me and they said, we don't want to talk about it in the hearings, but a lot of the delivery systems that you are praising are losing money and they are in danger of going bankrupt. Now, how do I answer that question? What do I say to them? And so as we play this out, because we need to continue to do this, we need to continue to put pressure on the system. It's all well and good that we stayed under the benchmark, but we need to keep doing that. But, what I think we're going to face, unless the delivery system itself changes, is increasing pushback from all components of it saying, you can't cut hospital rates, you can't cut admissions, you can't cut this and that. And we're going to have to try to find that balance when all gets said and done. So I think, David, our staff needs to be, I think all the list that was made, whether it's, moving to more consolidated payments, social determinants, I'm with the secretary. I think we do have the goals in the matrix, metrics that are sitting there. Farmer is a big issue. I'm sorry. It's really an issue. And maybe we ought to be saying that no company that is spending less than 25% of its sales should be allowed to raise their prices at all, something like that. You're safe for another hour. Workforce, I'm a big believer in changing the workforce, but it doesn't mean we should just keep adding people. The idea of working to top of a license, I couldn't agree more. We need to be working hard, alternative payments shifting care, behavioral health. So we need to do all these things, and really, again, I want to share with my commissioners. I want to thank our staff, and I want to thank you, David, for all the work you did to put these together. But I think we laid out an agenda that's going to keep us busy for the next several years. And maybe you want to have the last word, David?
I just want to say thank you, commissioners. And really, no other state in the country has this hearing process. And I want to thank you for your incredible leadership over these last day and a half, for the hard questions that you ask. This is a public service that you do on behalf of the Commonwealth, and you represent the state so well. So I hope everyone just join me in thanking the commissioners for their great job.
Thank you. All right. Well, I guess, I'm having so much fun. We'll just keep it. And you know what? If it wasn't for Wendy here, we would go on forever. But we have to wrap it up. And we're adjourned.
Thank you.
Thank you, David. Thank you. Great job, David. Thank you.
Stuart, we're going to go up.